Hi, today I am going to talk about orotracheal intubation. My name is Sarit Valentina Sanchez Hernandez. Okay, indications. First, is indicate in any situation that requires definitive control of the airway. Is commonly deferred to facilitate control of the airway in a patient undergoing general anesthesia. Second, emergency indications include cardiac or respiratory arrest, failure to protect the airway from aspiration, inadequate oxygenation or ventilation, and existing or anticipate airway obstruction. Contraindications. The most common contraindication is when orotracheal intubation by direct laryngoscopy is someone contraindicated in a patient with partial traction of the trachea because the procedure can cause complete cessation and loss of the airway. In this case, surgical airway management may be necessary. Important, when immediate intubation isn't required, this difficulty of intubation should first be assessed. This assessment is discussed in detail in the preparation section under sedation and paralysis. Continue with equipment. First, gloves. Second, protective face shield, working suction system, back valve mask attached to our oxygen source, endotracheal tube, internal carbon dioxide detector, stethoscope, and laryngoscope with appropriate blades. Okay, we continue with procedure. It's very important to maintain all antiseptic and aseptic standards. First, position your body so that your eyes are far enough from the patient to facilitate binocular vision. Second, while holding the laryngoscope with your left and open the patient's mouth with the right hand. Third, insert the laryngoscope blade to the right of the patient's tongue. Fourth, gradually move the blade to the center of the mouth, pushing the tongue to the left. 5. Slowly advance the blade and locate the epiglottis. 6. The tube should not obstruct your view or the vocal cords during this critical part of the procedure. Continue pass the tube through the vocal cords until the balloon disappears into the trachea. Remove the stylet and advance the tube until the balloon is 3 to 4 centimeters beyond the vocal cords. Inflate the endotracheal balloon with air to the minimum pressure required to prevent air leakage during total volume ventilation with a bag. This usually requires less than 10 milliliters of air. Ever have an assistant maintain cricoid pressure until you have confirmed that the tube is in the trachea. And finally, secure the endotracheal tube to the patient's head and you have confirmed that the tube is in the proper position. You should use an endotracheal tube holder to secure the tube. This helps prevent accidental displacement. Complications. The most serious complication of endotracheal intubation is unrecognized esophageal intubation, which may lead to hypoxemia, hypercapnia, or death. It's important to know the laryngoscopy can provide vomiting and aspiration of gastric contents, causing pneumonitis or pneumonia. Additional complications include bradycardia, spasms, bronchospasms, and apnea, owing to perineal stimulation, trauma to teeth, lips, and vocal cords, and exacerbation of cervical spine injuries can also occur. Thank you for seeing this video. Bye bye.